Welcome everyone to the GP Contracts in England webinar. I'm Richard Vortfy, Chair of GPC England, and I'm going to be presenting to you the outcome of our negotiations and the planned changes for 2021-22. This webinar will be recorded, so it will be made available to view later if you want to go back to it or to refer colleagues to it at another time. I'm going to make a presentation of about 25 minutes. And then I'll be joined by other members of the GPC England executive team, Mark Sanford-Wood, Krishna Kasarani, Farah Jamil, as well as Ben Molyneux, Chair of the Sessional GP Committee. And we're supported by Dan and by Nick from the BMA staff team, who will be reading the questions that you put through, maybe during the presentation or during the evening, and then fielding those to us. I'm going to start the presentation. This is an overview of the agreement that we've made with NHS England, but it's worth remembering that this is the third of our 5-year contract agreement. In order to support the continued response of general practice, particularly during the COVID-19 pandemic and the amazingly successful vaccination programme, we have secured agreement with NHS England to make minimal changes from the 1st of April 2021. Including delaying some of the previously agreed elements that would normally have started in April. I think this is recognition of the really challenging times that we're in, and the recognition also that we need to continue to focus on the delivery of the vaccination programme, and we cannot be distracted from that at such a critical time, both for our patients and for the nation as a whole. This presentation sets out the interim contract agreement from the 1st of April. A small number of changes will be implemented, mainly related to funding commitments already made to assist in the pandemic and its impact. And these arrangements will remain under review depending on the progression of the pandemic. No one quite knows what's going to happen in the next few months. We can hope for the best, but we also have to prepare for the worst. And so further changes will be agreed between NHS England and GPC England to reflect the current circumstances at the time. This is the funding that will go to practices from the 1st of April. You can see that practices in this third year of the agreement, 2021-22, will receive an uplift to the contract of £253 million overall, which includes allowances for pay uplifts at 2.1%, expenses uplift at a similar 2.1%, and also takes into account a variety of funding pressures, not least population growth, the additional Section 7A funding for vaccinations, immunisations, and some additional funding that we've secured for QOF. Need to take this into the context when government have already indicated that there's likely to be a wider public sector pay freeze or restraint in the coming year. And inflation is running between 0.6 and 1.2, depending on how you calculate that. So a rise of allowing for pay to increase by 2.1% and an annual increase of 3% is quite significant. These are the figures for global sum, for the out of hours adjustment, and for QOF. The value of QOF will go up by 3.3% to £201.16p per point. Similarly, global sum will rise to £97.28. And that's a rise overall of 4.1%. There isn't an out of hours adjustment. This is the money that is taken effectively from global sum to fund the equivalent of out of hours services and relates back to the opt-out arrangements from 2004. There have been some changes to QOF, but they are minor, modest changes. The most significant change, though, is the transfer of the vaccines and immunisation arrangements from particularly the childhood immunisation domain into QOF. So whilst there's been a transfer of about £60 million from the childhood immunisation DES into QOF, the actual work involved doesn't change. It remains a priority for all of us to ensure all our children are vaccinated as effectively as possible, and that work doesn't change. But what has changed is the arrangements for funding that, which we hope will be simpler and will improve uptake overall. We have, though, secured some additional money of £24 million into QOF from April to strengthen the serious mental illness physical health check indicator set and hopefully to support uptake of that. We've also revised the wording for the cancer indicator, and we've split that into 2 indicators, and I'll show those in a moment about how they will operate in the coming year. So overall, the size of QOF increases from 560 points to 635 points, and the main reason for that is the transfer of the vaccination and immunisation and the creation of that new domain. What hasn't changed from this year to next year is the focus on learning disabilities and supporting early cancer diagnosis in the QI modules. We know that some practices had already started work on that, doing their audits, trying to improve the uptake of learning disability medicals and activities, and also the focus on supporting early cancer diagnosis, particularly during these challenging months of the pandemic, where we saw a fall in referrals for particular cancers as patients did not present in the same way as they once did. That's now changed, and we've got back to referral levels very similar to previously, but nevertheless we need to look at that and see what improvements that we can make. So the learning that some practices may have already made during this last year can be transferred to the coming year, and that will apply to the QI modules for 21-22. Of course, we're still in the midst of the pandemic, and so remote working, when it's clinically necessary, will continue to be an acceptable way of delivering QOF reviews. These are the indicator set for the serious mental health indicators and the cancer QOF indicators. So you can see that we've added in additional indicators to the SMI domain. One which was previously in QOF was taken out and then has now been put back in again, and that's measuring alcohol consumption for this group of patients. And then new indicators related to identifying those with problems with lipids or with an elevated HbA1c. In the case of lipid profiles, that could be done every 2 years or every 1 year for those patients who are prescribed antipsychotics or have a pre-existing cardiovascular condition or smoke or are overweight. More than likely, most patients will simply have the 2 blood tests done as one each year. We know these patients are at significant higher risk of morbidity and mortality as a result of cardiovascular and other conditions. And so we need to try and support our patients as best as we can by identifying problems early. We've made changes to the cancer indicator, effectively splitting it into 2 areas of focus. The first will be a focus at around within 3 months of diagnosis, giving a patient the opportunity for a discussion or informed support from primary care, although we know often in the early time of cancer diagnosis, most of the care will be provided by the hospital. The new indicator will now focus on a longer time frame, so within the preceding 24 months of a cancer diagnosis, and this will be using the templates, the structured templates that are already within EMIS and System 1 and other systems. The biggest change is relating to vaccinations, immunisations, and this is related to a 2-year project, and this is the 2nd year of that project, so it completes the process. It's important to recognise that the funding within Global Sum that funded the additional service for vaccinations, immunisations has been fully retained. So all that funding is still within Global Sum, and that's to recognise the work done in call and recall and the administration of vaccination and immunisations and outbreaks when we see major or indeed national outbreaks, and that will be funded separately if that was necessary. What we have done is made a significant change to the payment mechanism and incentive arrangements for the vaccine coverage. As I've said, it was a phased approach over the last 2 years. Initially, we did this with MMR in this financial year, but now it will apply to all childhood immunisations, and all of them will now attract a £10.06 item of service fee. Practices, by and large, will be achieving well over the 80% target of the target payment arrangement, and so will receive the £10.06 for all of those patients that they vaccinate. But practices achieving less than 80% of the target cohort will not receive the full payment for the first 50% of their cohort, but will receive an item of service for each immunisation administered above the 50%. This effectively means that there'll be a sliding scale of payment, and the full payment for all patients will be received as practices achieve 80% of the target cohort. You'll know at the moment that the enhanced service has a target of 70% and 90%. And currently, practices that don't hit that 70% payment threshold get no funding at all. That will change with these arrangements. So it will mean that all practices start to receive income for patients that they immunise once they achieve that 50% threshold. In limited circumstances, where practices may be able to retain the full payment when coverage remains low as a result of some particular patient or patient list demographics. As I mentioned, the current arrangements have these cliff edge arrangements, 70% and 90%, where you can do an awful lot of work, have 67% coverage or 88% coverage, and then get nothing because you haven't achieved those particular targets. That now will change, and these current simplified arrangements will benefit all practices. Practices, we hope, will receive a monthly aspiration payment. We're still working with NHS England on that to ensure that that becomes possible. And then it will be reconciled at the end of the year, because most practices' immunisation achievement is comparable one year to the next, similar to the level that they would achieve with QOF. We hope additional investment means significant majority of practices actually should gain from these new arrangements. And the Investment and Impact Fund, the IIF funding, will also encourage influenza uptake at PCN level. So these are the new indicators that will go into QOF related to achievement of vaccinations, immunisations. And the thresholds mirror sort of the World Health Organization targets, and they also link in with the funding arrangements and the item of service arrangements that will kick in at 50% of uptake, and then will be fully paid at 80% of uptake. And so practices should benefit not just from achieving these indicators once they get above particular thresholds, but also from the item of service payments as well. So it's important to see the total funding pot as the funding investment related to this important area of work. We have been discussing with NHS England the potential for a greater focus on obesity and weight management. Particularly, we've seen this in the pandemic, that obesity is a significant risk factor in terms of COVID-19 and the serious impact that is having on our population and our patients. We have, though, decided that rather than having any indicators at this particular point in time, we'll do some further work with NHS England, and we'll look to introduce an enhanced service later in the year as we do some further work and ensure particularly that weight management services are available to refer to and are open and accessible in all parts of the country. We want to ensure our patients get the right level of support, and we need assurance that these services will be in place before we can introduce any new arrangements. This is the current situation relating to primary care networks. As you can see, the average size now of a primary care network is just over 48,000 population size, and there's over 1,200 primary care networks in England, ranging in different sizes, but 99% of practices are now involved in their primary care network. And we've seen how beneficial that's been in the work that practices have been able to support one another, particularly during this last year, during the COVID pandemic, and not least with the vaccination programme. We are following the resolution at the LMC England conference in November 2020, where it was resolved that conference notes that the BMA GPC England had not secured a robust democratic mandate for the PCN-DES in the past, and so they asked us to seek that mandate from the entire profession by means of a ballot, and that's what we did. So we held the ballot in January, recognising this was a really difficult time for a ballot to be held, but nevertheless we got a good response, a valid vote of over 4,500 responded, and 80% of respondents said yes to the ballot question that prior to any further negotiations, extension or changes to the 2021-22, GPC England was to be given a mandate for the PCN directed enhanced service. Thank you to all those who took part in that ballot, and we now go forward with confidence that this is the right thing to do for the profession. We'd already agreed some changes, or some funding arrangements for the PCN DES for this coming year, remembering this is the third year of our 5-year agreement. And so the funding arrangements for the network participation funding and the core PCN funding, those remain the same. The funding for each care home bed is now £120. You remember that the care home service specification started mid-year during this last financial year, and so we got £60 per bed in this year. It'll rise to £120 for the full year going forward. Where we have seen a significant increase in funding in the coming year is in the ARS funding. This is the funding to support the workforce expansion for primary care networks, rising from £430 million to £746 million, a significant amount of money to invest in expanding our workforce to help deal and manage with our workload pressures, and to have staff working in our practices to see our patients and to expand our services as it's appropriate to do so. The Investment and Impact Fund, again, was modified during the pandemic year, and that was £24.25 million after its amendment. That will rise back to the planned £150 million for the next financial year. The access schemes comprise of two elements. There's the extended hours scheme, which you will remember that was responsibility of individual practices. That's £87 million. And the extended access scheme, that's for weekend and evening appointments, and that's £367 million, taken together £454 million. The original plan had been to bring those funding together and to make them the responsibility of primary care networks from April, and to allow primary care networks to fully utilise all those appointments as they felt appropriate. But we felt that it was not the right time to do that, and so we've delayed the full implementation until April 2022, so a year hence. However, there are some areas that already deliver both the extended hours and extended access schemes, and they can continue to do so. And there were some who are already planning to do that. And again, they can carry on with their plans if the Commissioner agrees and if the local primary care networks are ready to deliver those services. The changes that we've made to the ARS funding I've already alluded to, and that will allow for increased expansion, not just of the number of people, but also additional roles that we've extended from 10 to 12 in October, and then the further inclusion of paramedics, advanced healthcare practitioners and mental health practitioners from April. We've increased funding for the IAF, as I've just mentioned, and the additional 4 specifications that, again, were planned to be introduced from April have now been reprioritised and will be delayed in their implementation. So there are no current plans for their implementation, and we will await the outcome of the next few months before making any firm decisions about when those service specifications should be implemented. Will there be a more phased approach to the introduction of the new IAF indicators for 21-22, and I'll mention a bit more about those in just a moment. And as I've said, the access offer, which was planned for this year, will now be implemented in April 22. We've also made changes to the pharmacy scheme. So clinical pharmacists who are currently still on the old scheme can be transferred to the ARS between the 1st of April and the 30th of September. So there's a final opportunity to do that. We've also made important changes to allow practices in the London area to utilise their funding with greater flexibility to apply London weighting. So some of the new workforce groups that you can now, as a primary care network from the 1st of April, recruit include paramedics. We know that some areas have already got paramedics working within them as part of various pilot schemes. This will enable all areas to recruit paramedics. For those who have a Band 7 level qualification or experience, the PCNs will be able to engage them, with the ability of the PCNs to engage at the top of Band 6. If a paramedic doesn't have level 7 capability in clinical practice, they will be engaged via a rotational model as part of a training pathway, maybe with a local ambulance service, until they reach the necessary expertise, and then the PCN could take them on if they wanted to. There's a whole range of colleagues who may acquire or have advanced level practitioner skills. So this applies to clinical pharmacists, physios, occupational therapists, dietitians, podiatrists, and paramedics. And so there will be the opportunity to reimburse these professionals who have the necessary skills and expertise at a band 8A level. Initially, this will be limited to one advanced practitioner per PCN. The much larger PCNs, over 100,000 population, will be able to take on 2 of those. And hopefully this will provide a test bed for future development of this area. One important area that we will enable practices and PCNs to take on are mental health practitioners. So PCNs will be entitled to an embedded mental health practitioner employed and provided as a service by the PCN's local provider of community mental health services, and that will be funded under a local agreement. What this will mean is that working with your local mental health trust or other community mental health provider, they will provide 50% of the funding for this practitioner, and the PCN will provide the other 50% of that funding. So effectively, this draws in more money into the ARS as part of this arrangement. In the first year, 1 whole-time equivalent MHP will be able to be employed. That increases to 2 next year, and then 3 in 2 years' time. For PCNs with more than 100,000 patients, then the entitlements will double. And staff will be additional to any other mental health practitioners who are already co-located with general practice teams. So this is bringing in additional capacity of expertise with a mental health perspective, and hopefully as well, by doing so, breaking down some of the barriers between PCNs and practices and the Community Mental Health Trust, and enabling smoother referrals when a referral is necessary to take place. As I mentioned, clinical pharmacists that remain on the clinical pharmacist scheme and general practice scheme will be able to transfer to PCNs and will be reimbursed under the ARS. And that transition period will last until the 30th of September. And for PCNs in the London region, the maximum reimbursement amount per role within the ARS will now include inner and outer London weighting on top of the maximum current ARRS reimbursement amount. And so this will enable greater flexibility for those practices that have struggled with recruitment because of the inability to make allowance for London weighting. The PCN DES service specifications will be delayed. They won't be implemented in April 2021, and we'll be talking with NHS England about when any implementation may take place. We have, though, made some minor modifications to the SMR and the early cancer diagnosis service specifications that will continue from 2020 into 2021-22. So this relates to the type of drugs that the SMR process may focus on, for PCNs to review and identify any specific actions around unwarranted variation in cancer outcomes, particularly bearing in mind the pandemic. And PCNs will be encouraged to play an active role in encouraging and facilitating the sharing of capacity for cervical screening across the practices within their network. But the other arrangements that currently pertain with the SMR and early cancer diagnosis service specifications will continue. There are no changes planned for the care home service specification, which will also continue. So as with the current services, there are no targets with any of the future service specifications. All of the indicators and the targets related to them will be within the IAF once that's been agreed. Now, there were 4 further service specifications planned from April, and these won't happen now in April. This was cardiovascular disease and diagnosis and prevention. This is primarily identifying patients with hypertension not yet known to practices, or maybe patients with atrial fibrillation, tackling neighbourhood inequalities, anticipatory care, jointly, predominantly with community service providers, and developing greater focus on personalised care. All of these services you will require additional recruitment of staff to enable them to take forward. And so the delay in implementation really does provide a real opportunity for practices to work together to employ and utilise that additional funding in the ARS to recruit more staff and to expand the workforce in preparation for any service specification implementation maybe later in the year. So in order to support practices and PCNs with their pandemic response, This is why we've done this, to try and ensure that the focus continues to be on the COVID vaccination programme. And remember, ARS staff can be used to support the vaccination programme. The Investment and Impact Fund was restarted in October 2020 with low value medicines indicator and low carbon inhaler indicator removed from the previous planned changes. So the 4 indicators that are currently remaining in 2021 were the flu indicator for over 65s, learning disability health check indicator, a social prescribing indicator, and the medicine safety indicator related to co-prescribing of PPIs with gastroprotection with drugs such as non-steroidals. All of those indicators, except the medicine service indicators, will continue into 2021-22. As I mentioned, the IF funding will increase to £150 million, and we're going to be having discussions with NHS England in the coming weeks and months around what indicators could be applied to measure these particular areas. So particularly focusing on the impact of the COVID response and also tackling health inequality, something that's really been exposed as part of the pandemic, something that all of us have a responsibility to try and tackle where we can within our communities. We'll be focusing on vaccine uptake, including flu vaccines and maybe other vaccines. PCN services, such as supporting the delivery of the service requirements when they're implemented. There will be a focus on access. This is something that was agreed previously about sensible supporting improved access and experience in general practice without reverting back to previous mistakes with 24, 48-hour access targets, which simply weren't sustainable or sensible. And then also a focus on sustainability, a really important area for general practice to play its part in trying to reduce carbon emissions and to support the NHS net zero commitment. Now, we were planning to combine and simplify the access schemes. This was planned for April this year, but will now be delayed until April 2022. This combines the extended hours scheme and the extended access scheme and was a significant resource when brought together. The access scheme will continue to be used to support the COVID vaccination programme as it is at the moment, and it's intended that practices and PCNs could use the combined scheme to undertake routine work at different times of the day, so doing health checks or smears or immunisations, SMRs, or to reduce core hour practice workload by moving some activities from the daytime into evenings or weekends that would actually improve access for patients, but also help manage our workload pressures as well. Having access to these appointments will be important in the future, and it's something we're keen to work with NHS England to implement appropriately. Digital services will be encouraged, and particularly the learning from the pandemic about the benefits of enabling flexible home working and shared arrangements with neighbouring PCNs in delivering some of these extended access arrangements. And we will, as soon as we have them, publish further details once we've agreed them with NHS England. We all want to ensure that general practice is a good place to work and that our workforce have good contractual terms and conditions. And we know that most practices ensure that this is the case. We will be working with NHS England to undertake a data collection survey to get an accurate baseline of the current terms and conditions of practice staff in this next year. And following this, we'll develop good practice guidance on employment terms and conditions in general practice, which we also intend to publish in year, so we can try and ensure that all practices do what the vast majority of practices are already doing, and that's offering good terms and conditions, not just to their GPs and their practice nurses, but to all their practice staff. We're also going to explore how general practice gender pay gap information can be made more transparent in a way which both respects individual privacy and doesn't result in undue additional burdens to practices, but which actually starts to help us to address this gender pay gap, which is there in general practice as it is with any other field of life and other organisations. As in most years, we've got a number of digital requirements that we will be needing to focus on, but this year particularly, we've got the experience of the pandemic to fall back on. And in most cases, most practices are doing all of these things already, whether it be online, whether it be offering online consultations or using video consultation tools where it's appropriate to do so, having two-way secure written communications between patients, carers and practices in place, having an up-to-date accessible online presence and signposting to validated symptom checkers, sharing record access when it's appropriate to do so with our patients, and requesting and management enabling requests for prescriptions online and online appointment booking. The ability to utilize total triage and triage first models will continue going forward, and practices will enable patients to use online methods to inform them increasingly of some of the demographic changes that might take place. So when they change their address or contact details, it may be that the patient may be able to make those changes themselves and so reduce practice workload by doing so. There are other items that we're continuing to discuss with the Departments of Health and Social Care and the NHS England and improvement. The bureaucracy review that we've been part of is exploring changes to fit notes and DWP reports and other requests from practices to reduce practice workload. We intend to retain the improvements and reduced workload of appraisal, and that will continue in the coming months. The intent to simplify the contract by transferring the cervical screening additional service into essential services doesn't mean that there's anything different that practices need to do. It's simply about reducing some of the elements within the wording of the contract and actually simplifying it without practices actually making any changes to what they're currently doing. Clarification that digital services will be allowed to be delivered by contractors through locations other than practice premises. Again, that's in line with the experience of the pandemic, with more and more people working from home. And the removal of the requirement for patient consent to use the electronic ERD made under the pandemic regulations. And so the dispensing arrangements will become a permanent change. And a contractual requirement for more timely transfer within 28 days of patient records when patients move between practices will be introduced. And in summary, we have also been very mindful of the impact of the pandemic, and as you know, and I'm sure you're very aware, made significant changes to the way that we've been able to support practices during the last year, not least with levels of income protection, the £150 million that we secured as part of the Capacity Expansion Fund for Practice Workforce Expansion Support, the COVID vaccination programme funding arrangements, and then the opportunity to refund some of the rebooking that took place for the second appointments in January, and also funding to support some of the admin costs in the early parts of the vaccination programme. And as a result of all of that, practice groups have responded quickly and effectively, delivering approximately 70% of all vaccinations, a massive achievement, and thanks to all of those people involved in delivering that. So in summary, this is a contract that delivers increased funding, which is above inflation, to both practices and to PCNs. The vaccination immunisation item of service arrangements and QOF changes will remove the current enhanced service, but there's no new work involved in that. The £24 million additional for QOF is for the mental health domain. There's increased ARS workforce options, London waiting flexibility, and 50% additional funding added to cover the cost of mental health workers. We've delayed the service specifications and the IAF until later in the year, and digital changes that we've put in place are in line with the experience of practices during the pandemic. And above all, we've continued to focus on supporting practices with the pandemic response and the COVID vaccination programme. The BMA is always there for you. If you're not a BMA member, please do consider it, because we want to be able to be supporting every GP throughout the country through the work that we do, both locally and nationally. And we want to be there for you, and we will do all we can to ensure that you continue to be able to deliver services for your patients and get the best support there is to be provided. Thank you. I'm going to bring back now the rest of the team and ask if Dan or Nick have questions for us.
Yeah, so I think we'll start off with some fairly easy ones to ease you into it. So I think first one, Farah, there's some around QOF and Vaccinims. So is the item of service payment for Vaccinims the £10 and 6p per vaccine or per appointment? Because there's a lot of vaccines, a lot of jabs in one appointment for some people.
Yeah, so this is specifically an item of service fee, so it is per vaccine administered.
And then the other one related to QOF was about it being protected. It's protected this year. Will it be protected into 21-22?
Yeah, so as you can imagine, we completely appreciate and understand the challenges on the ground in terms of, one, responding to the pandemic, the backlog of work that will eventually, snow us under, and also the vaccination program in itself, which is quite an undertaking. So the very first slide that Richard spoke to articulates that this is something that is moving, and we are continuing to have conversations with NHS England. At this moment in time, what we can share is that we continue to push for further amendments. However, the contract as published in Jan is currently the state of play at this moment in time.
Thanks. I think there was another one related to QOF and the pandemic, and that's around, so from April, practices will still be doing first doses and second doses, and they will also, be providing routine services, dealing with COVID and standing up the services that they've done through the pandemic. So I guess this is for Farah and Richard. How will practices be able to return to business as usual if QOF is running as normal?
Yes, I tried to pick this one up in the previous response, and I think it's very much a case of revisiting as necessary as the response to the pandemic evolves. So at this moment in time, we are where we are with respect to the contract agreement. However, we continue to remain in ongoing discussions about what this could mean for general practice in terms of their response around the vaccination program and any additional workload that comes their way. Richard, you might want to come in.
Yes, I mean, I should add that vaccinations is core business for general practice. We deliver a massive flu vaccination campaign every year. We deliver many childhood vaccinations. Clearly, the COVID vaccination program has been of a magnitude far greater than that. But it's quite likely that we will be vaccinating for a significant amount of time. Maybe boosters might be required during the autumn or the winter, and then maybe this might be a recurring feature for the future. We just don't know. And so what we need to do is plan for the future, and maybe vaccination should become part of our core business. We need to ensure the funding is there in place for that, but also we need to employ the necessary staff to be able to do that. And whilst GPs and many others have stepped forward in vaccinating initially, we need to ensure that we've got the right skilled people vaccinating longer term, so that we can support business as usual, including vaccinations going forward, because we need to recognise that we have to support all of our patients, and general practice is really key to that.
So I think, Krishna, there's some around ARRS and funding for PCNs. Will there be, someone's asked, will there be an uplift in ARRS salary bands for this year?
Yes, the ARRS recruitment bands will essentially go up in line with the expected pay uplift for staff, which is 2.1%. So the banding for each role will reflect that increase for next year onwards, and how you pass that on to your staff contractually is between you and the staff. But our advice would be to pass that on to your members.
And then there's a sort of follow-on from that, which is what will happen to any unspent ARRS funding?
This does come up on a regular basis, like any part of the enhanced service funding. So these are entitlements that we can draw down upon. Unfortunately, if we don't get to draw down on those, it remains with the commissioners, but we continue to make representations about making sure, particularly this year where we needed extra support, that all of that funding, one form or the other, is made available back into general practice so that staff can be recruited and supported through these challenging times. The overall pot for ARRS will go up again next year, and there will be an element of that challenge again, but we'll continue to make sure that the workforce is supported the best we can.
There's another one around funding, this time around premises for the ARRS staff.
So the funding for premises-wise, it's a challenge, and it's been a challenge even before the PCN DES came into place. And in 2018, when we asked the question about practices and how prepared they are about having premises that are suitable for future, 80% of GP practices said that they're not fit for any future needs. So we have so far made representations to the spending review twice to make sure that there's significant uplift to the infrastructure funding for general practice, because if we are to host 26,000 additional multidisciplinary workforce in general practice, as well as recruiting extra GPs, we need some space to put them. We're very conscious of the challenges that the lack of premises investment essentially poses for general practice, and we'll continue to push that with the Treasury and the government to make sure there is funding available for now and for our future needs as well.
Just had a question in specifically around London waiting. And it asks, the London practices will be reimbursed for London waiting for the additional roles. Will there also be an uplift to the overall budget for the PCN ARRS within London?
The ARRS allocation is as per before, so essentially the overall pot doesn't change. But what has been the problem for London practices is that because of the London supplement, you were not able to actually get 100% reimbursement for that. So this essentially now means you're able to recruit and account for inner and outer London waiting, but not for the fringe waiting. But the overall allowance for that PCN does not increase. It stays, well, it increases in line with the expected increase, but it doesn't go proportionally higher than other PCNs with similar populations.
And there's one which is sort of crosses for you and Farah, I think, which is around IT support for the ARRS staff. We've mentioned premises support, but there's a question around IT support as well. Who wants to take that one?
All right.
Yeah, I'll respond to the IT support. I think we've repeatedly made the case for appropriate support, not just with IT, but also with premises. So understanding that if we're talking about 26,000 new additional roles, then there's got to be somewhere to staff them, and there's got to be the right equipment to provide them to provide the care. So it's certainly been heard. The question is how it's going to be supported. So my understanding very much is that CCGs, as part of their GPIT operating model, will get clear allocations, rather than the newspeak ICSs will get clear allocations, but I'm still waiting to see the current GPIT operating model, which is due for April. So until I see it, I cannot, faithfully answer that question in terms of what additional funds there might be, but certainly heard by NHS England and other colleagues at NHSX about the need to support with the right IT infrastructure.
I think back to Krishna, there's quite a few questions around mental health practitioners and the arrangements for those within PCNs. Some saying that PCNs had already planned to employ a mental health practitioner, so this shared arrangement with mental health providers means those plans cannot be carried out. Some saying mental health providers themselves weren't prepared for this arrangement and they haven't got the funding to do it. And then some around mental health providers where the PCN cuts across various mental health providers, more than one. How does that arrangement work?
Okay, sure. So I think the first point in terms of the 50-50 arrangement and why that's structured in that place, you'll remember in year one of the PCN DES as well, we've had a similar challenge with availability of workforce. So we capped the number of clinical pharmacists and social prescribers to 1 per PCN. The intention this time around is roughly on the similar lines to make sure that every single PCN in the country is able to access and engage a mental health worker, so that the ones that are well prepared don't necessarily end up recruiting everyone, and the ones that are already struggling due to other challenges may end up with nothing at all. So the intention is 1 per PCN this year. That will continue to go up in subsequent years. The 50-50 funding element of that is to ensure that mental health practitioners in particular, I'm sure most of us have shared these frustrations where getting access into mental health provision at the community and secondary care is deeply frustrating. So unless they are embedded into that, where the journey for that patient is seamless from the point of contact with general practice to community mental health and secondary care provision, it will end up being difficult to navigate. So that's one of the rationales for it. the frustrations around mental health providers not being fully informed on these changes. After the standard contract, which is what community mental health trusts work under, has been put out consultation in January. The consultations have now closed. So if locally your mental health providers aren't familiar with those changes, then they should revert to those documents which are published on the NHS England website. But the mental health providers contract, the final version of the NHS standard contract, will be published shortly, obviously ahead of April, so they will know what's expected of them. And the intention with this isn't that you are forced into only engaging in this way around. It's in a way, it works in our favor with respect to local discussions between the commissioners and community mental health providers. If the offer that's been put on for PCNs locally you feel isn't good enough for you, there is no obligation for you to take this on. So this is just as much in the interest of the commissioners and the mental health trusts to make it work, as it should be a benefit for PCNs across the board. I forgot the third question, Dan. Sorry if my second one response was too long.
The third one.
Oh, mental health providers that cut across more than one CCG. So that will be discussions between the respective clinical commissioning groups and the PCNs. I suspect we're referring to whereby a practice has brand sites across CCG boundaries. That currently happens now, and that will be a local adjustment made. And in the discussions, you obviously need to have with both providers in the same way that when you were looking at multidisciplinary team approach for enhanced health and care homes, you'd have to look at two lots of community nursing service provision and so
on. There was a similar question around paramedics and struggling to agree a contract for paramedics through the ARRS because of issues with the ambulance service, and they're having a management overhead costs. Is there a national solution to this?
So on that, it really does depend on which level the paramedics are at. So if you're able to recruit at band 7, you can recruit them directly in line with other ARS roles. So there is no obligation there to employ them through the paramedic ambulance service at all. It's only if they're not at that level, because those paramedics are still sort of considered to be almost in training to work at a general practice level, you'll need to have those discussions with the local ambulance trusts. But if they are at higher level than that, at 8 or above, for advanced practitioner level, again, you will be allowed to recruit 1 per PCN to in year 1 until the advanced practitioner framework is structured, where you will be able to do that as well. If you are struggling with discussions locally, I would flag that with the LMC straight away and involve the CCG in those discussions. And certainly, if there are themes that are emerging, LMCs will get in touch with us, and we can flag those up nationally with NHS England and come back to you with solutions. But by all means, please do start your discussions early on.
So there's a few questions around PCNs that are also related to the pandemic. So I'm not sure who will want to come in on these ones, but there's one around an uplift for payments for clinical directors, which we've seen the payments increase over the pandemic period. And then there was one around tackling neighbourhood inequalities and how the pandemic has worsened these, and how this can be tackled. Who wants to come in on those?
This is a clinical director.
Yeah, certainly. So what was the question regarding the CD payments, Dan?
So it was, is there going to be an uplift for clinical director payments for the next year?
Well, certainly we've already agreed that there will be the extra additional payment in Q4 of this financial year, so between January and March. And I think that's, as a recognition for the work that that many CDs have taken on, particularly in terms of leading the vaccination programme. Certainly in my own PCN and declaration of interest, I am a clinical director. We have chosen to spend that money in recognising the amazing work that's been done by our practice managers and administrative staff in helping to set that up. So that's something that's already there. What was the further question?
It was around tackling the neighbourhood inequalities. It's the service within the PCN coming up, but the pandemic has worsened health inequalities. So
Yeah, and we recognise that the pandemic has widened health inequalities, and that's absolutely certain. As Richard pointed out in the presentation, the service specification for tackling health inequalities is being delayed in terms of its introduction. That doesn't mean that PCNs shouldn't start moving on trying to tackle those inequalities. I mean, that's certainly something that as doctors and as practices, where I'm sure we would want to work on. What it does, though, at the moment is that it removes any contractual obligation to produce any particular output. But we will be working on that. We're continuing to discuss with NHS England what those service specifications might look like and when we might start to feed them in.
There are a couple of more related to service specifications. One is around the care homes service spec around smaller learning disability homes. Are they included in the care home payments within the DES? And also around local LESs and LISs for care homes. Should those payments be carried on in 2021, 22, or does the PCN service spec supersede those?
So regarding which homes are eligible for the care home premium as per the contract documents, it's the ones registered in the CQC as care homes that provide service to older adults. So if the care homes are catering for younger population, then that they won't necessarily be covered by that. But that will still open up an opportunity for discussion locally, particularly in view of what's happening in the last few months, to have that discussion, because I think it's from a national contract agreement point of view, it's very difficult to cater for all variations of it, but it's certainly something you should pick up. And if there are areas that you need us to tackle on those, please do again forward those through via your LMC, and then we can certainly have the discussion nationally as well. In relation to the second point, which I've forgotten that.
So this is local enhanced service arrangements.
Local enhanced services.
I mean, in many ways, these what has been applying over the last 6 months should really carry forward, sort of, for the future as well. So some areas will have had additional requirements, sort of, through local enhanced service arrangements, and it's perfectly appropriate to continue to secure funding for those additional requirements that are over and above the national service specification.
I think we'll move on from PCNs because we are coming up to 5 minutes until the end. There are a few around digital. So will there be any guidance about allowing patients to access records or changing their own records?
Yes. I've already picked it up, haven't I, Dan? So yes, in short, yes, there will be guidance, but there has been tons of guidance already. What we're currently working on, though, is trying to simplify the ask in itself. So we're still in ongoing discussions about what online access to records should look like, and trying to make this less onerous for general practice. I think there's a further question later on down the line about whether it was costed or not. And I think the key thing is this is part of a contractual framework. So the whole contract is taken as a whole rather than each individual section within a contract agreement. So coming back to access to records, we recognize the challenges related to safeguarding or related to redaction. We've articulated this repeatedly. The team at NHS England get it, and they're keen to find a way to make this work for us in general practice, but equally wanting to ensure that the vast majority of patients who don't have those significant issues which require things like additional time being spent redacting can gain value from access to their records. So we are currently, literally earlier today, had a discussion about what further guidance could look like and how we can simplify the process for general practice, including how we might be able to support general practice to deliver the same.
There were a couple around salary GPs and locums, which Ben might want to come on. One was firstly around the workforce survey that was mentioned. Will that include salaried and locum GPs? And the second one is around workforce resilience and staff support, specifically with staff being exhausted, risk of burnout, and risk of early retirement, etc. Ben, I don't know if you want to come in on those ones.
Yeah, so in terms of, if we take the second one first, in terms of burnout, I think that affects all of us equally, regardless of which type of GP you are and which bit of the NHS you work in. Certainly, the BMA's been looking really carefully at the, we've been doing tracker surveys for the last nearly a year now, and the rate of burnout questionnaires being responded to is going up. So we're really mindful of that. And one of the things we are looking with NHS England colleagues at all of the workforce initiatives going forward, from actually meeting them tomorrow to start planning what next year looks like to try and support the workforce, whether that is the retainer scheme for GPs, whether that is flexible working, you name it, it's on the table. So I think that's something that we don't have an answer to yet, but it's certainly something that we are looking to address going forward. And the first question was about workforce surveys, is that right?
So I think this was around, I think this question came in around the looking at terms and conditions for practice staff.
Yeah, so we've been involved in the initial discussions about that. I don't think we've got as far as an agreement as to which staff and how, but certainly my perspective is that I would want as many sessional GPs to be included as possible, because it gives us better data. So while we're a slightly distinct group from other practice staff, I still think it's important to gather opinions and get that information. And I actually want it to include those who work in non-practice settings if we can. So those who are working in extended access or in out of hours or UTCs, for example, because that's a whole unknown set of the workforce we don't really have much intelligence on. So that's what I'm pushing for. We'll see what they come back with.
There was also one which Mark might want to come on around GP appraisals. Will they go ahead in April? Will GPs be able to opt out if they're too busy with COVID work, etc.?
Well, certainly at the moment, whether or not you have an appraisal is entirely up to you. The default option for most of the country has now moved back to not having an appraisal unless you ask for one. But if you want one, you can go ahead. I think the really important thing is that the framework for the appraisal has now changed, so that the new sort of MagLite form is there. It's all of the previous requirements for evidence and a whole reams of paperwork has gone. And so certainly the people who are doing them are people who have found that it's been a very positive experience. For those people who don't want to do an appraisal this year, then they can have an allowed missed appraisal. We assume that that will continue through into April. There are no plans to change that at the moment. If the emphasis of appraisal changes again in future following discussions, then obviously we will communicate that to the profession.
I'm going to switch back to Ben. There's a question around DDRB. Have they released their recommendation yet for salaried GPs? And if so, is there a danger that the global sum uplift could be at risk?
So last year's DDRB uplift, hopefully you're aware of. So that hopefully is something that you already passed on to your, if you're an employee, you've already passed on. If you're an employee, you've already received it. We're currently in the final stages of putting through our evidence for the next round. So next month we'll give out oral evidence, and then if we're on schedule, and we may not because of COVID, in the early summer we should get a final recommendation from DDRB for next year. So we are currently mid-cycle and in the kind of regular kind of evidence process at this point.
Okay, Chris, a quick one. There have been a few questions coming in around practice managers and accessing the new to partnership scheme. Is that still going ahead?
Well, we're working on it. We're really hoping it would be, but it's not at the moment, purely down to how it needs to be structured for practice managers. But we'll keep you updated as soon as that comes online.
We've got, I think, a couple of minutes left. One, maybe Richard, I don't know if you want to come on this around the access scheme. If practices are ready to take on the access scheme in the middle of the year or during the year, will they get a proportion of the money, or does everyone just need to wait until April next year?
Yes, they would get a proportion of the funding. Obviously, the extended hours element of the funding is already within all PCN budgets. So this would be the additional funding from the the wider access scheme. You obviously need to agree it with the Commissioner, because the local provider for the access at the moment needs to be given appropriate notice and then transferring the responsibility from them to the PCN. But some PCNs are already planning for that. Some already deliver it, but depending on how much you do is how much you'll get paid.
There's a couple left around the vaccination programme and COVID. So is there any indication as to whether GPs will be doing COVID jabs later in the year? I don't know whether that means as boosters or as a continuation of the vaccination programme. There's a lot of mass vaccination sites being set up at the moment. So will GPs still be involved in the vaccination programme?
Well, the current vaccination programme is just for cohorts 1 to 9. So that's up until we've vaccinated all the clinically vulnerable people and those older than 50. We are wanting NHS England and the government to make decisions around what will happen for the rest of the population. That will in part depend on JCVI advice, which we would expect to come through very shortly, and we'll be negotiating with NHS England on general practice's role going forward. But as I intimated earlier, I think general practice has played an incredible role in the delivery of the vaccination programme so far, and we're well placed to continue to provide vaccinations to all of our eligible population if we've got the resources to do so. And I'm sure many practices would want to be able to continue to do that. Whether there's a need for booster vaccines in the autumn or the winter will very much depend on evidence, and as soon as we know that, then we'll be able to inform practices accordingly.
And a related one around vaccinations, the COVID vaccine being administered at practice level rather than at groups of practice level. Is that coming?
Yeah, well, it's unlikely that the Pfizer vaccine will move beyond designated sites, just because of the logistics and the challenges relating to that. And we are coming towards the end of Pfizer in terms of the amount that government has bought. So we obviously got enough for the second doses, but then we'll be moving predominantly to AstraZeneca Oxford vaccine being provided through designated sites. We would anticipate that there's more opportunity for practices individually within their PCNs to deliver that vaccine from their own practice sites, because of the ability to move that if you've got appropriate cold chain storage arrangements in place. But nevertheless, some practices may want to continue to work within those designated sites because of the opportunity to do that in a shared way, as they've done with the flu campaign as well. The government and NHS England are likely to continue to deliver, just because of the logistical reasons, the AstraZeneca vaccine to designated sites, and so it's unlikely to be delivered individually to individual practices, certainly not this year. There's also a challenge of ensuring that we avoid wasted vaccines. So if you've got vaccines spread out amongst more practice sites, there is always that risk, because they will continue to have vaccine delivered in multi-dose vials, that there's more opportunity for vaccines to be wasted, and no one wants that to be the case. So I think there is still lots of benefits in working together in PCNs to deliver vaccination, but we want increased flexibility to be able to deliver it appropriately, and also to improve access to vaccine for particular communities who would prefer to get the vaccine from their local practice rather than from a site that they're less familiar with.
We've got a few other ones. Mark, I wonder whether you want to address one around CQC inspections in 2021. Will they change? Will they be the same?
Yeah, so at the moment, CQC have again indicated that they're suspending routine inspections. So right now, the only inspections that should be taking place of CQC have been where there have been serious causes for concern that have been flagged up. Now, that's the situation at the moment because of the pandemic. As we move into the spring and infection rates fall and hopefully hospitalisation and mortality rates fall, then I'm sure that they will revisit their policy around that. So I expect that CQC inspections in some form will start up later in the spring or the summer, depending on how the pandemic progresses. But at the moment, it's important to stress that there is no routine inspection activity.
We've had a few other questions in, which I think we can probably cover in our guidance as we update that over the next few weeks. But I think an interesting one to end on is around what do we think the impact of Brexit will be on GPs and GPs' work. I don't know who wants to take that, or if you all want to give your personal opinions on that.
Well, I mean, one of the things that we want to see happen as a result of Brexit is actually a change in the VAT arrangements for PCNs. We know this is an issue that many clinical directors, many PCNs, have had concerns about. We were always told that the arrangements were in place because of EU legislation and EU arrangements applying to VAT. Well, now we're no longer in the EU, and so we would want the Treasury and the government to really look again, at this, and to remove the VAT responsibilities from PCNs. PCNs deliver healthcare, and we shouldn't be getting tangled up in VAT issues. And we would hope that the government can address that now that we're outside the EU.
Okay, we're 5 minutes over. I don't know if anyone has any last comments they want to make.
Well, I think on that point, I think we may be able to draw to a close. We will be doing another webinar tomorrow. So if you've enjoyed this particularly, then you can come back for a second helping tomorrow. So maybe get different questions, or invite other people to bring other questions, and we can do that and answer those questions tomorrow. We will, as Dan has said, be taking all of these questions and others that we haven't been able to answer to look at our guidance and to make sure that they're all addressed through that. And so, please do, if you've got questions still, either let your LMC know or contact us directly, and we can try and provide you with the necessary support and answers to your questions. I want to thank Dan and Stephen, who hasn't been able to join us today, but helped with the presentation, and to Nick and to all of the team for taking the evening to support this work. We're here for you, and we want to provide as good a possible service to you. We want to ensure you have the best possible contract within the funding arrangements to deliver the best possible care to your patients, and we'll continue to try to do that to the best of our ability. Thank you for joining us. Good night.